Hello, my name is Dr. Aleena Banerji. I'm an associate professor at Harvard Medical School and the clinical director of the Allergy and Clinical Immunology Unit at Massachusetts General Hospital in Boston, Massachusetts. I'm going to start with our first session today, talking about hereditary angioedema, current and future treatment options. The first part will focus on current treatment options. These are my disclosures. Our learning objectives for this first session are to review the current guidelines and unmet needs of patients with hereditary angioedema. We'll also talk about the current clinical data that has been published for treatments that are available for patients with hereditary angioedema. To get us all on the same page, we'll start by looking at the initial guidelines and how we approach treatment. And this covers three main goals in the treatment of hereditary angioedema. The first is the treatment of acute attacks, or treating an attack when it starts, with the goal of improving symptoms as quickly as possible. The second main goal is what is called long-term prophylaxis. And this is giving patients with hereditary angioedema regular treatment to decrease and prevent the overall number and severity of attacks in hereditary angioedema. And the third goal is termed short-term prophylaxis. And this is giving treatment to reduce the likelihood of swelling in response to an anticipated event that might precipitate an attack. And this could include a surgical procedure or a dental procedure that is scheduled. Putting these three goals into context, we often think about the guidelines, and there are numerous guidelines that have been published, including from the WAO-EACI, the United States Hereditary Angioedema Association, the Canadian Hereditary Angioedema Guidelines, there's pediatric guidelines. But these guidelines are very consistent in some of the core principles that we talk about in terms of managing patients with hereditary angioedema, and we'll talk about these throughout the rest of the presentation. First and foremost, and again consistent across guidelines, is to make the initial diagnosis as quickly and as accurately as possible. And what we know is that the majority of patients do present with symptoms as teenagers, if not earlier. If a patient is presenting with initial onset of symptoms in their 40s or 50s, then we may not be talking about hereditary angioedema with C1 inhibitor deficiency. And as you can see in this publication, most individuals have initial onset of symptoms around 12 years of age, and this varies slightly in hereditary angioedema with normal labs, but again, patients are presenting with symptoms by the time they are teenagers in the majority of patients that have hereditary angioedema. What has been of concern when you look at these registries or in the literature in patients with hereditary angioedema has been the delay in diagnosis. And what you see here are average delays in diagnosis of more than 5 years out to 10 years. And we have seen this in past years be even longer. But if we can make the diagnosis early and as quickly as possible, then we can help that patient get the right treatment at the right time. In terms of diagnostics, we will talk a little bit about the different treatments. But when you ask patients in this survey, thinking about your most recent attack, please rate the severity of that attack. What you see are a variety of symptoms, which includes fatigue, abdominal pain, abdominal swelling, nausea, diarrhea. In addition, not only are these symptoms very common, but the disease burden is very high. And as you can see in red are the severe symptoms versus in purple, which is moderate, and blue is mild. But again, what this shows is that the disease burden has a variety of symptoms, but the disease burden is also severe in a lot of these patients. In addition to talking about the symptoms, The burden of disease for hereditary angioedema is multifactorial, and this includes the disease course, which we already talked briefly about with the delays in diagnosis, but also the misdiagnosis. We see that patients that are inaccurately diagnosed often present to the emergency room. They have had unnecessary surgery because their symptoms were not recognized as hereditary angioedema. We also know that there's a big burden of the attacks themselves. They can be very painful, they can be very disabling, they can be very disfiguring, and certainly life-threatening, especially when they involve the airway. Separate from the disease course and the nature of attacks, we have to think about the treatment and the costs. Oftentimes, the treatment itself can have a high burden, not only of dollar value, but the indirect costs. So the missed school, the missed work productivity, the need to go to the emergency room or be hospitalized in the middle of having an hereditary angioedema attack. And lastly, and maybe very importantly that we can't forget, is the impact on quality of life. Patients are reported to have high levels of anxiety, depression, they're missing out on social activities, they're not necessarily able to travel. And so all of these factors that impact disease burden certainly need to be thought about when we think about treatment of patients. Let's now move to talking about the pathway, which will frame how we think about the treatment options that are available and are in development for patients with hereditary angioedema. Patients with hereditary angioedema are missing the C1 inhibitor protein or missing the function of C1 inhibitor. And so in this pathway, starting with factor 12, you see that it's activated to factor 12A, acts on prekallikrein to form kallikrein, which acts on high molecular weight kininogen to form bradykinin, which acts on the B2 receptor. This pathway is normally inhibited by the C1 inhibitor protein, which is important because then you do not have unregulated production of bradykinin. However, in patients with hereditary angioedema, they are missing this inhibitory effect of C1 inhibitor. And so the pathway is unregulated, which leads to elevated levels of bradykinin, which acts on the B2 receptor. And that is what is responsible for the increase in vascular permeability and the symptoms of swelling that we see in patients with hereditary angioedema. Thinking specifically about the diagnosis in patients that have hereditary angioedema with C1 inhibitor deficiency, we focus on talking about two different types of hereditary angioedema. The first type is the most common and is about 80% of patients. They do not produce the C1 inhibitor protein. And so when you look at the lab tests, and we're talking about the C4 level, the C1 inhibitor level, and the C1 inhibitor function, they do not produce the C1 inhibitor protein, so their C1 inhibitor level is low and the function is low along with a low C4 level. In hereditary angioedema with C1 inhibitor deficiency type 2, which is about 20% of cases, they produce the C1 inhibitor protein, but it is dysfunctional. And so when you look at their labs, the C1 inhibitor level is going to be normal, but it does not work. And so the C1 inhibitor functional level is low, and the C4 level is also low. And so it's very important when we're making these diagnoses that we always look at the C1 inhibitor function, because if you only look at the C1 inhibitor level, you will make a misdiagnosis or you will miss the type 2 C1 inhibitor deficiency patients. The third type, which is a little bit more rare, is what we call hereditary angioedema with normal labs. These patients present with symptoms that are very similar to hereditary angioedema with C1 inhibitor deficiency, but their labs are normal. And what we understand now is that there are some mutations in other proteins in the kinin pathway that I showed you earlier. When we look specifically at what are those mutations in patients with hereditary angioedema with normal labs, we have identified 6 mutations to date, and that includes the kininogen mutation, the plasminogen gene mutation, the myofurlin gene mutation, a heparin sulfate glucosamine 3 sulfotransferase mutation, or also shortened to be HS3ST6. We know that there are mutations in factor 12, and lastly, mutations in angiopoietin. And all of these lead to the clinical symptoms of hereditary angioedema that we see in these patients with hereditary angioedema with normal labs. Let's move on and talk a little bit about treatment, and this gets back to our guidelines. Again, guiding principles that are present in the majority of guidelines that are out there, looking at the WAO guidelines, the Canadian guidelines, the US HAE guidelines. And let's focus on the first treatment category that we talked about, which was on-demand or acute treatment, so giving treatment at the onset of symptoms. And what the guideline would say is that there is efficacy and safety across a variety of treatments for on-demand treatment, and this includes C1 inhibitor concentrates, a plasma kallikrein inhibitor, as well as a bradykinin B2 receptor antagonist. And we'll talk a little bit more about the data for these products in the next few slides. We also know that fresh frozen plasma is often effective for on-demand treatment, but it contains the mediators that can lead to increased bradykinin generation, and so can exacerbate some HAE attacks. And so if you use fresh frozen plasma because you don't have access to any other treatments, you do have to closely monitor that patient to make sure that the attack is not worsening. We also know very clearly that androgen and antifibrinolytics are not effective treatments for on-demand treatment. And also epinephrine, corticosteroids, and antihistamines, which are often used to treat allergic reactions, are not effective in hereditary angioedema because this is a bradykinin-mediated process. So let's talk a little bit about the data from the specific therapies leading to FDA approval. And as I mentioned, one of the first treatments that is available for on-demand treatment is a C1 inhibitor replacement product. And this is data from the pivotal trial where they studied C1 inhibitor replacement at 10 units per kilogram on demand, as well as 20 units per kilogram on demand. And what you see in the figure is the placebo dotted line compared to the C1 inhibitor replacement product, or Berinert. And this led to the approval of the 20 unit per kilogram dose of Berinert, or the C1 inhibitor replacement product, because of the statistically significant difference of placebo versus giving 20 units per kilogram on demand of the C1 inhibitor replacement product. The next on-demand product that I mentioned was ecallantide, which is a kallikrein inhibitor. And in this trial now, almost 10 years ago, looking at two different measures of outcome, the MSCS as well as the TOS. And what you see in the patients that were given ecallantide on demand was a statistically significant improvement in symptoms at 4 hours compared to placebo. And these data led to the approval of ecallantide for on-demand treatment. So next, I want to talk about icatibant, which is a subcutaneous treatment given on demand that was approved for HAE. And again, as you can see from the data on this slide, when you compare the data for icatibant being given on demand versus placebo, that patients given icatibant had statistically significant improvement in symptoms compared to placebo. And this was also seen in the secondary endpoint looking at time to onset of symptom relief. And this led to the FDA approval of icatibant for on-demand treatment. And the last or fourth available treatment in the United States for on-demand treatment is a recombinant C1 inhibitor product. So this is a C1 inhibitor protein that is a recombinant protein made in rabbits. And in this pivotal trial, they studied giving 100 units per kilogram intravenously, as well as 50 units per kilogram intravenously. And what you can see looking at the red line, which is the placebo, is statistically significant improvement in primary and secondary outcomes with the recombinant C1 inhibitor product compared to the placebo or saline in this study. This led to the FDA approval of recombinant C1 inhibitor given at 50 units per kilogram for on-demand treatment. So summarizing these four on-demand treatments, what you see is both a plasma-derived C1 inhibitor product and a recombinant C1 inhibitor product given intravenously on demand. So the disadvantage is that it does require intravenous access, but the advantage is that there's a lot of clinical experience and really good data that these are effective on-demand treatments. Ecallantide, which I mentioned, was a kallikrein inhibitor, also highly efficacious in the pivotal phase 3 study, but about a 3 to 4% risk of allergic reactions. So ecallantide does have to be given subcutaneously under the supervision of a healthcare provider. And then lastly, icatibant, which I mentioned was the bradykinin receptor antagonist, is a subcutaneous injection, and it's stable at room temperature. But patients have noted some local injection site reactions in some cases when they give icatibant to themselves for treatment of an on-demand attack. So looking now at all of the therapies, we talked already about the on-demand treatments, but let's move on to talking about the long-term treatment options, which are highlighted in green on this slide and include, going back to 2008, a human plasma-derived C1 inhibitor product, or Cinryze. And then in the last 6 to 7 years, in 2017, another plasma-derived C1 inhibitor product, or Haegarda. In 2018, a human monoclonal antibody to plasma kallikrein, or lanadelumab. And then most recently in 2020, an oral plasma kallikrein inhibitor, or berotralstat. So let's look at each of these therapies given for long-term prophylaxis. And what are the guidelines for long-term prophylaxis? And again, very similar across all of the guidelines that I mentioned, but the therapies are available and reasonable for all patients with hereditary angioedema, and it's recommended that every patient is evaluated for long-term prophylaxis at every visit, and the disease burden and patient preference should be taken into account when making decisions around long-term prophylaxis. The recommendation is C1 inhibitor, as well as lanadelumab and berotralstat for first-line agents, whereas androgens are second-line agents because of the side effects associated with androgens. In terms of the data, we'll go back to 2008, which I mentioned was the first therapy approved for long-term prophylaxis. And so this was data giving C1 inhibitor as a replacement product twice a week intravenously. And what you can see on the slide are showing that patients given C1 inhibitor twice a week had statistically significant improvement compared to patients with placebo. And the attack rate was significantly lower in patients receiving C1 inhibitor prophylaxis twice a week compared to patients being given placebo, leading to the approval of this product to be given twice weekly intravenously as long-term prophylaxis. And then fast forward to more recently, this is data for long-term prophylaxis with a product called Haegarda, which is given subcutaneously, but as a replacement C1 inhibitor product. And what you see in the dark green is the data of attack rate for the placebo arm compared to 2 different doses of the C1 inhibitor replacement product. And what you see is a statistically significant decrease in the median attack rate looking at the C1 inhibitor replacement product compared to placebo, which led to the approval of this product for long-term prophylaxis given twice weekly subcutaneously for long-term prophylaxis. In addition to the efficacy data, what they showed was statistically significant improvement in different quality of life tools, showing that not only was there efficacy, but there was improvement in quality of life looking at several different surveys when you gave long-term prophylaxis with C1 inhibitor twice weekly subcutaneously. Moving on to the next product, this is long-term prophylaxis with lanadelumab, which is a monoclonal antibody to active plasma kallikrein that can be given for long-term prophylaxis subcutaneously once every 2 weeks or once every 4 weeks. And what you see in blue compared to the gray, which is placebo, is a statistically significant improvement in the attack rate when you looked at lanadelumab treated patients across the treatment period compared to placebo. And in both cases of the overall treatment period as well as during steady state, there was a statistically significant decrease in the attack rate in patients on lanadelumab compared to those on placebo, again leading to the approval of this product in the United States for long-term prophylaxis. And similar to what I showed you with the data for the C1 inhibitor replacement product given subcutaneously showing improvement in quality of life, similarly in the trial with lanadelumab, you saw a much higher clinically meaningful improvement in quality of life measurement in patients that were given lanadelumab compared to placebo. So not only efficacy, but also clinically meaningful improvement in quality of life. And then the last product that is available for long-term prophylaxis and FDA approved in the United States is berotralstat. This is a once-a-day oral treatment for long-term prophylaxis, and looking at the pivotal data, what you see is a significant improvement in the attack rate in patients given a once-a-day tablet of berotralstat compared to placebo. And you saw that there was a significant reduction in the attack rate looking at the percentage of patients with 50% or greater, 70% or greater, or 90% or greater attack rate compared to placebo. And again, similar to the other two products that I reviewed, berotralstat had a high safety profile as well as improvement in quality of life. And then most recently at the American College meeting in 2023, long-term prophylaxis data from an open label extension study of berotralstat at 150 milligrams once a day was presented, and they showed that berotralstat was well tolerated and had a good safety profile similar to the phase 3 study. But in addition, this open label extension study showed that berotralstat continued to have a sustained reduction in attacks compared to the patient's baseline attack rate over a longer period of time, suggesting that a reduction in disease burden and that there was a durable treatment effect when you looked at these data from the open label extension study. So in summarizing what we talked about, there are 4 different therapies that are FDA approved with good safety profiles, including a plasma-derived C1 inhibitor product given intravenously twice a week for long-term prophylaxis, a subcutaneous C1 inhibitor product given twice weekly for long-term prophylaxis, lanadelumab, which is given as a subcutaneous injection once every 2 to 4 weeks, and then most recently berotralstat, which is an oral once-a-day tablet given for long-term prophylaxis. We didn't spend a lot of time talking about the attenuated androgens, and they are considered second line because while they are efficacious and do provide good efficacy for long-term prophylaxis, they unfortunately do have a lot of side effects, including hepatic toxicity, impacting cholesterol profile, amenorrhea, causing hypertension, compared to these other 4 therapies that I reviewed with you, which have a lot better safety profile. And then the antifibrinolytics, an example is tranexamic acid. It can be used off-label for treatment of hereditary angioedema for long-term prophylaxis, but again, it's considered second line because of the number of side effects that are associated with that line of products. And so to summarize, we've talked a lot about hereditary angioedema treatment. We've reviewed both on-demand and long-term prophylactic therapies that are available and FDA approved, that are efficacious in reducing the number and severity of attacks, but also improving quality of life. There are many advantages to these therapies, but there are some disadvantages and that may impede compliance. And so we can talk a little bit about some of the newer data as well as new treatment options that are in development that was presented at the American College in our next session. This second part is going to focus very much on the treatment advances in hereditary angioedema highlighting the new data from the American College meeting in 2023. Our objectives for this session are specifically to review some of the newer data presented at the American College meeting in 2023, held in November in Anaheim, California. What we'll talk about in this section is to focus specifically on some of the newer advances in treatment options for patients with hereditary angioedema. We'll focus a lot on the newer data presented at the college meeting around investigational treatments that are in clinical trials at this time. The first therapy that I want to talk about is garadacimab. Garadacimab is a monoclonal antibody that inhibits activated factor 12. In this phase 3 study, patients received garadacimab 200 milligrams subcutaneously once monthly for up to 6 months, but this was after the 400 milligram initial loading dose. The primary endpoint or monthly number of attacks was assessed, as well as data looking at the percentage of attack-free patients at weekly and monthly intervals. What you see in the purple figure are significantly reduced number of attacks in patients receiving garadacimab compared to placebo, and also a very favorable tolerability and safety profile. The post-hoc analysis presented showed that garadacimab provides early onset and durable efficacy in the reduction and prevention of HAE attacks starting as early as week 1. Looking specifically at the data, what you see is a decrease in mean monthly attacks at week 1 down to 0.11 compared to 1.81 in the placebo arm. Looking at the attack-free rate, what you see is in the garadacimab group in weeks 1 through 4, a decrease or attack-free patients 92 to 97% compared to 50 to 66% in the placebo arm. These data are very promising for a new therapy for long-term prophylaxis in patients with hereditary angioedema. Next, we'll look at the open-label efficacy and safety data for garadacimab from ongoing phase 2 and phase 3 open-label extensions. The primary endpoint was treatment-emergent adverse events in patients with hereditary angioedema with C1 inhibitor deficiency. And as we would expect, the safety and efficacy was similar to what was seen in the phase 2 and phase 3 studies with garadacimab, again showing a favorable safety profile with similar durable efficacy with a decrease in monthly attack rate. In addition to the efficacy data, garadacimab in the open label extension studies had improvement in quality of life. They looked specifically at the angioedema quality of life tool, as well as the subject global assessment of response to therapy. And what you can see is a clinically meaningful and long-term improvement in these quality of life measurements. This was very similar to what was seen in the phase 3 study. The next therapy that I want to review is donidalorsen. These are data presented at the college meeting from an open label extension study where they wanted to look at the safety, efficacy, and quality of life in the open label extension study. So this was in follow-up to the randomized phase 2 study in patients that was treated with donidalorsen, and that phase 2 study did show a mean 90% reduction in HAE attacks compared to patients in placebo. In the open label extension study that was presented at the college meeting, patients were either on a fixed dosing of 80 milligrams every 4 weeks, or flexible dosing of 80 milligrams every 4 weeks, 80 milligrams every 8 weeks, or 100 milligrams every 8 weeks. And in this open label extension study, 14 of the 17 patients completed 2 years of treatment. And data confirmed that donidalorsen was well tolerated and did have the efficacy that was seen in the phase 2 study. Again, showing sustained durability of efficacy, low treatment emergent adverse events, and confirmed the findings that were seen in the phase 2 study of donidalorsen. Looking again at additional data from the open label extension study for donidalorsen, what we saw is that there were no treatment emergent adverse events that were occurring drug related in more than any one patient. There was a mean reduction in monthly attack rate of 83% from baseline. And this also was consistent, showing an improvement in quality of life compared to baseline in patients in the open label extension study. The next therapy that I wanted to review is deucrictibant. Deucrictibant is an immediate release capsule that is orally administered and is an antagonist of the bradykinin B2 receptor. These are data from the on-demand placebo-controlled phase 2 trial of deucrictibant. It was given at a dose of 10 milligrams, 20 milligrams, and 30 milligrams and compared to placebo. And what they found was a statistically significant improvement in the estimated median time to end of attack with all 3 doses compared to placebo, and that the majority of attacks treated achieved end of progression of treatment by 24 hours. Again, showing that there is promising therapy for an oral on-demand treatment for patients. Let's move on to look at some real-world data that was presented at the college meeting in patients with hereditary angioedema. Another important study that was presented at the college meeting helped us understand that patients with hereditary angioedema are not actually carrying their on-demand treatments, even though that is recommended across all guidelines. This specifically was a study conducted by the U.S. Hereditary Angioedema Association in patients with hereditary angioedema, and they were asked to complete a 20-minute self-reported online survey in the fall of 2022. And what they found is that almost half of patients are not carrying their on-demand treatment when they leave the house. The reasons for this were interesting, and it included in the majority of patients that they prefer to just leave it at home. In about half of patients, they reported that they forgot to take it with them. In another half of patients, they were afraid that if they took their on-demand medication with them, they would leave it somewhere and not have it back at home. And also, about 40% of patients reported that they didn't carry their on-demand medication with them because they were on long-term prophylaxis. I think this reminds us that patients should understand that attacks can occur spontaneously, and they can be laryngeal attacks, which can be life-threatening. And so it's really important for us as the physicians taking care of patients with hereditary angioedema to remind them that they should have their on-demand medication with them at all times, and at least 2 doses of on-demand therapy, which is what is consistent across all of the hereditary angioedema guidelines. In another very important study, they addressed the lack of data in underrepresented minorities in patients with hereditary angioedema. They surveyed in a non-interventional observational web-based format, specifically of racial and ethnic minority members of patients with hereditary angioedema. And what they found was that a lot of these patients had a very difficult journey, including a significant delay in their diagnosis of hereditary angioedema. They also avoided seeking medical care prior to their diagnosis of hereditary angioedema in almost all cases. And lastly, a significant number of misdiagnoses in these patients. What is reassuring, though, is that once they did have a specialist that understood hereditary angioedema, that they were satisfied with the care that they received for their hereditary angioedema. In this next study, looking specifically at patients with hereditary angioedema with normal labs, we understand that there is a significant unmet need in these patients. So this was conducted in 30 physicians across 15 countries, looking specifically at physicians who treat hereditary angioedema. Looking at treatment patterns, they found that more than half of patients were using on-demand treatment only, About a third of patients were using on-demand treatment as well as prophylaxis, and that icatibant was the most commonly prescribed treatment for patients with hereditary angioedema with normal labs, while tranexamic acid was the most commonly used long-term prophylaxis. But in terms of an unmet need, it was found that having a treatment that was specifically studied and approved for patients with hereditary angioedema with normal labs was an unmet need, as well as the availability of an oral treatment. Importantly, it was felt that the development of a reliable, validated, and easily accessible biomarker to accurately diagnose patients that have hereditary angioedema with normal labs was needed, and it was really needed not only to diagnose these patients, but also to improve the management and guide treatment options for these patients. In this next study, we're looking specifically at the burden of illness in adult patients with hereditary angioedema, and this was a non-interventional cross-sectional web-based survey of almost 300 adults across a variety of countries in South America and Europe. What we found was that the burden of disease continues to remain high in patients with hereditary angioedema, despite the availability of treatments. This included a report of approximately 11 attacks in the last 6 months, a third of patients reporting an attack in the last 7 days, and 7% reporting that the last attack affected their throat or larynx, which could be potentially life-threatening. So more than half of these patients were on long-term prophylaxis, but they continued to have a high frequency of attacks that was impacting their quality of life. So still showing that we have a lot of work to do in improving the care of patients with hereditary angioedema to address this high burden of illness that they're facing. The next two studies that I'll review look at the burden of illness of caregivers. In this study, 55 patients were surveyed who were caregivers to pediatric patients with hereditary angioedema. The mean age of the pediatric patients was approximately 4 years at onset and around 10 years of age at the time the survey was completed. And what the survey identified was that these pediatric patients had a mean number of attacks of 6 in the last 6 months. So about once a month they were having attacks. Almost half of them reported an attack in the last 4 weeks. 14% reported that the last attack impacted the larynx, again, potentially life-threatening. That there was an impact on school and work for not only the pediatric patients, but also the caregivers. And that there was a significant impact on sleeping, causing anxiety, including impacting relationships with family and friends. And so there is a lot of work that we have to think about for the caregivers of patients, of pediatric patients with hereditary angioedema. And in follow-up to that is data looking at the burden for caregivers of adult patients with hereditary angioedema, again showing that there's a significant number of HE attacks, that there is a significant amount of anxiety, sleeping problems, missed day of work, that these patients' caregivers do also need our support, our help, discussion with how best to support the caregivers, not only of the pediatric patients, but also of the adult patients. And it's an important aspect that's often forgotten about, but these data clearly show that there's something that providers and physicians taking care of patients with hereditary angioedema need to think about. So to summarize, I think we've shown some very interesting data for investigational therapies for patients with hereditary angioedema, including garadacimab, donidalorsen, and deucrictibant, showing promising efficacy with good safety profiles. We also showed that many patients are not carrying their on-demand therapy and that there is work left to do for those of us that take care of patients with hereditary angioedema. We also have work to do in the racial and ethnic minority groups where the difficulty in obtaining a diagnosis is still significant. But once the diagnosis is made, that these individuals are satisfied with the care that they're receiving. and that there's still a high burden of disease for patients and caregivers and patients with hereditary angioedema with normal labs. And so some work for those of us in the field to think about as we're taking care of patients and thinking about research paths. Thank you for your attention.